I'm Jessie Solomon-Sanders, and I am the vice chair of the AAN section on adults with intellectual and developmental disabilities. And my specialty is neurodevelopmental disabilities. I'm assistant professor at University of Colorado. And most importantly, really excited to have Dr. Maya Ayoub here, who is a senior, almost finished with residency, PGY 5, and going to be specializing in neurodevelopmental disabilities very soon as well. So here to talk with us about transition and all of, not all, because there's never a way to talk about all, but many of the things we often don't get to in the conversations that we've been having. So really looking forward to where Dr. Ayoub leads us today in the conversation about transition challenges.
Great, perfect. Thank you so much. Thanks so much for, thinking of me and including me in this meeting. I'm very excited to hear everyone's thoughts and to present the case presentation. So what we had discussed was doing a very short case presentation at the front, so maybe around 15 minutes. So I'm just going to set my timer on the side for myself, and then we'll leave a lot of time for discussion around this case presentation. That way we can all kind of hear. I'd love to hear from everyone's input from their own experiences in clinics, as well as struggles that have been similar to this case presentation. So to start off, I'm a PGY5, just as Dr. Sanders mentioned, at UCLA, Mattel Children's Hospital. I'm excited to be specializing more in neurodevelopmental disabilities. And so today my case presentation is focused on a 19-year-old male who presented to the pediatric neurology clinic, actually with breakthrough seizures. Feel free to stop me anytime as we go through with questions. So all of the information in here is de-identified with fake names. So this case presentation is under the fake name of Kevin Carson. This is a 19-year-old male with Lenox-Gastaut Syndrome, LGS, who has been seizure-free for about 9 years, presenting for breakthrough seizures. Mr. Carson, again, has been seeing his pediatric neurologist for seizures since about age 13. He transferred care at that point from another state, and he was last seen by his pediatric neurologist about 5 months ago, but has had intermittent kind of distant visits over the past 6 years when he's been seeing them. He presents today with his father, who has had conservatorship since about 18 years of age. Before the last visit, Kevin had gone about 9 years seizure-free. However, at the last visit, parent reported that he had about 2 seizures, both in the setting of missed doses. Kevin, who forgets all of his seizures, said, "That makes sense." But then at this visit, parents reported 5 more seizures between the last and this one, and Kevin himself was surprised to hear about this. Currently, he's on monotherapy with Epidiolex and had trialed many medications in the past before finding seizure freedom on Epidiolex. He was seizure-free on the Epidiolex for 3 years before even presenting to our clinic from out of state, and so he continued on this medication and just made intermittent weight-based adjustments throughout the time. So to go a little more into his seizure semiology recently, so some of these seizures, which had been kind of breaking through in the past year or 6 months, had been witnessed and some had been unwitnessed. The ones that were witnessed showed behavioral arrest with stereotypies, so sometimes picking at his nails, sometimes lip smacking, followed by tonic stiffening and emesis. The ones that were unwitnessed were noted by the emesis in his postictal period. Each of these seizures were lasting less than 2 to 5 minutes, and they were self-aborting on their own. The frequency, as I mentioned, so he went through about 9 years with no seizures, then had 2 seizures in December of 2023, and then had 5 seizures between January and May of 2024. When we went into more of a discussion about possible triggers surrounding these seizures, parents and Kevin opened up more of a discussion around what's going on in his social life right now. So now that Kevin graduated high school in June of last year, he started a vocational program and had been dedicating about 2 days a week to working at the local grocery store. He's also been continuing to bond with all of his friends, and several days of a week, he's been playing video games. Although parents were trying to limit how much he's playing at night, he'll sometimes evade them, and when they sleep, play late into the evening and miss sleep. Additionally, since November of last year, since he started this vocational program, parents decided to also help him start administering his own medications. When the first breakthrough seizure happened in December, parents started spot checking his medications and noticed that around half of his Epidiolex suspension was being missed at different times. Initially, they started working on checking the medications a little more closely with him. However, after the 3 more breakthrough seizures in February and March, they took back the responsibility and started administering the medication themselves. The 4th seizure happened that first week as he was still getting back into the medications. And the 5th seizure happened from low sleep in a week when parents noted he was playing a lot of video games with his friends. So as you can tell, even though Kevin had had triggers or provoking factors in the past 6 months, he also had been gaining a lot of weight. And parents had been noticing that his Epidiolex medication hadn't been titrated in a while because they had really been happy with his seizure freedom recently. So in December, in discussing with his pediatric neurologist, they up-titrated his Epidiolex from 6 mg per kg per day, again, a very low dose because he had gained significant weight in the period of time, just a little bit to 7. And then in January, they up-titrated it again to 10 mg per kg per day at their last visit. So I know we're all on the same page here, but just a really quick background on his specific condition. So Lenox-Gastaut syndrome, or LGS, a rare and severe epilepsy syndrome affecting about 1 in 2,000 individuals. Key features are listed on the slide, but have to include seizures beginning in childhood with multiple types of seizures. Nearly all individuals have the tonic seizures, as we see in Kevin, and the EEG features of a slow spike in wave and paroxysmal fast activity, as well as developmental delay and/or intellectual disability, usually coming on within the 5 years after the epilepsy onset. Now, Epidiolex, as we noticed in the case study, which Kevin is on, is FDA approved as an add-on medication for cases such as LGS, Dravet syndrome, and tuberous sclerosis. And RCTs that were done looked at a target maintenance of around 20 mg per kg per day, all the way to the ability to increase to 30 mg per kg per day, pending tolerability. But in practice, a lot of physicians go much higher than this amount too. So going back to Kevin's case, the rest of his past medical history, there isn't too much that's contributory at this time. His developmental history was significant for expressive language delay around 18 months and a regression or plateau at 2.5 years old. He was diagnosed with autism by a psychologist in formal testing at 3.5 years old. And then, as I mentioned, in his schooling, he graduated from high school and was now in a vocational program. Now, from his PMH, the thing I wanted to note was that there was also a concern from records that we did not have access to for ESES, or electrical status epilepticus of sleep, around the time of regression, around 2.5 years old, but unclear treatment was noted at that time. And he also had received genetic testing back in 2009, which was negative, but he was in the process of seeing genetics again to reevaluate those testing since it had been quite a while. So his current medications, again, were the Epidiolex, also a clonidine patch and oral clonidine, which he had been managing with his psychiatrist, because as these seizures were breaking through again, he was having significant behavioral outbursts and agitation that were noted between seizure events as well. Some noted by school and some by home, and to the extent of even causing harm to self during some of these bouts, as well as possible suicidal ideation that was mentioned to both parents and to his friends. And then, as I mentioned, his prior medication trials were really extensive before finding seizure freedom, surprisingly, on Epidiolex on its own. Sorry about the extreme text on this slide, but just to note that the physical exam really was non-contributory. So in mental status, he was awake, conversational with me, answering his questions appropriately, but needed a lot of prompting from Dad, particularly because he was shy and particularly because he was looking to Dad to answer some of the questions, but he opened up later in the exam. The rest was non-focal and no upper motor neuron signs were noted. And we were able to obtain an EEG directly following the visit, which showed frequent T3 and T4 temporal spike wave discharges, but no seizures. And again, we had access to his 2009 EEG, which had diagnosed the LGS. and had not seen ESES at that time, but had shown the features of LGS that I spoke about earlier on. So the 1 Hz spike and wave abnormalities, as well as the PFA, or the paroxysmal fast activity. So before I go into some of the discussion questions that I wanted to bring up in the historical context, I just wanted to ask if there were any other questions about the kind of medical or history of his case. And we're going to have a lot more time for discussions after. Okay, great. Oh, did someone unmute? Okay. So even though this is a simple and probably rather common case, I thought that there was a lot to discuss based on this. And I first wanted us to kind of read through and ponder some of the discussion points while I then go into the historical context that I thought was very significant for this as well. So some of the discussion questions that I had brought up, and I'm sure others will have more, were when and how do you introduce autonomy over medication administration to your patients? What resources have any of you used for helping teens and caregivers around medication education? And what's the balance between autonomy and supervision in cases where injury is likely from missed medications? Finally, how would the team decide, team including the physician, the parent, the individual themselves, decide that this isn't a viable responsibility for the individual? Versus when would you choose the adverse effect of another medication to continue to allow for a little more increased autonomy? So in thinking about this case and the discussion I wanted to prompt, part of what was important to me was the historical context of healthcare autonomy and medication knowledge. So conservatorship itself is a much larger discussion, which I won't cover today. But even in the assumption of appropriately assigned conservatorship, there's a lot to be said around personal education, knowledge, and autonomy in the administration of medications, let alone the decisions about the medications. So one large milestone, which is often referred to as the adoption by the UN of the Convention on the Rights of Persons with Disabilities. This document took a social model of approach to disability and was adopted in 2006 amid already transforming views and a lot of discussion in healthcare around autonomy of healthcare for those with disabilities. And so some of the seminal text refers to the quotes that I kind of put on the slide from the CRPD, which is respect for inherent dignity, individual autonomy, including the freedom to make one's own choices. Again, this in the specific case might be in tension with the conservatorship, but again, we're going to assume that the conservatorship was appropriately assigned. And then respect for the evolving capacity of children with disabilities. And I would even argue, even though this was mentioned in the children's article, for teens and for adults with disabilities and their evolving capacity. And so how well do we regularly do this in our clinical practice? A lot of data indicates that we might do this poorly, especially for individuals with disabilities. So in one scoping review that I looked at from 2019, there was limited data regarding medication teaching for adults with intellectual disability. There are limited articles focusing on this. And one of the studies showed that up to 24% of adults with IDD stated they received no information regarding their medications. Another study showed up to 45% didn't know their medications. And reasoning in some of these different articles that were reviewed around missed medication doses were anything from trouble breathing to pain and concern that their medications might interact with pain medications. Both patients and clinicians were asked in some of these articles about ways to improve this education of individuals with disability around their medications. And so some of the topics that were mentioned were varying the method of information that was presented, using mobile tools, or using interpreters, of course, when needed. And so when we think not just about the historical context, but about some of the tools that have been developed to help with medication education. And as I was talking with some different members of our team in other disciplines, so one of our social workers at UCLA and one of our care transition NPs, two tools that came up that are specifically used for epilepsy are the PACES and the EpiTrack. Now, it's important to note that neither of these tools are validated for individuals with disability, with intellectual and developmental disability, but I think they're interesting to look at as a method for education around medications. So the program for active consumer engagement in self-management was an 8-week course that's led by a psychologist and a trained peer with epilepsy. And it's meant to improve engagement and self-management of medications for patients with epilepsy. Now, the sample that it was validated in had higher education level, and the majority were insured, and the cognitive cutoff on the MoCA was about 21. However, when they looked at self-management scales directly after this 8-week course and 6 months down the line, there were improvements that were statistically significant and that were retained at the 6-month point. Now, the EpiTrack is another tool that was actually modified from the track. And so this is the Epilepsy Transition Readiness Assessment Questionnaire. It was validated and modified in Michigan Medicine. And right now, our nurse practitioner transition, who focuses on transition, is conducting research using EpiTrack with other centers. So this tool specifically focuses on topics of managing medications, appointment keeping, tracking health issues, talking with providers, and managing daily activities, and has patients rate themselves on a Likert scale about how ready and knowledgeable they are for each of these categories. Again, it's validated on individuals without intellectual disability, but it focuses on trying to get a baseline to then incorporate strategies and goal setting between appointments. Here is a sample of some of the questions that are used on the EpiTrack, specifically related to managing medications. And so now I want to open up the floor again to discussion after kind of setting some of this both historical context and some of the tools that are out there, but not specifically for our population, on any thoughts and any recommendations that other people in the audience have, as well as, recommendations for this specific case as well.
And can I ask before we get started? So in this group, we like to do introductions, but there's a lot of people here. So could everyone introduce themselves sort of in the chat? Just put your name and your specialty and where you are. Then we know who's part of the conversation and we'll be able to just keep it going. So awesome. Seth.
Yeah, hi, I'm Seth Keller. I'm here. I'm in New Jersey. I'm the past chair and founder of the section on adult IDD. And I do treat epilepsy as kind of a big thing on the adult world that I do. And I think it's a fascinating case. And I certainly appreciate you bringing the information and just a few clarifying questions about this individual. The person themselves, in terms of their level of functioning, and they're 19 years old. Is that how old this person is? 19?
Correct, 19.
So the question is their level of functioning, and I guess I know they live there with their family. Is that right? They live with their family member?
Yes, they still live with their family.
And can you give a general sense on the plans in terms of the future for this individual, in terms of staying with the family, working, living, going to a supportive living environment? Is there much? Can you describe that?
Yeah, I didn't delve in too much during my most recent visit because this was one of my attendings patients. But as far as we did discuss, they're in a vocational program and working part-time, and goals of kind of working a little bit more in the grocery store near their house. And for the immediate future, we're planning to continue living with their parents at this time, not going to any kind of assisted living facility. But again, those important discussions about kind of down the road care have not been had directly.
Because that's very relevant in terms of planning for discussion on all these kinds of questions you have. It's all relevant to, is a person going to be cared for by their parents forever? Are they going to go to group home? Can the person manage it themselves? So to be able to even answer a lot of questions, you have to really obviously get a sense of those kinds of things. So it's important to throw that into the mix, but thank you.
Yeah.
I think as always, Seth and I have so many different perspectives too and learn from each other, but I have patients who live independently but get help every day with medicine administration. So they
Right,
might not live
supportive
with their
living, they're in a
parent.
supportive environment, right?
Yeah, so the living situation isn't necessarily, and then there's patients that live with their parents that do their medicine completely independently. So
Right.
yeah.
And can I ask another question about the behavior? Because I know that we got some of our good behavioral colleagues on the call. Was it ever thought that some of the behavior is interictal or some kind of ictal phenomena that might be relevant to the seizure control? Was that thought about?
We were a bit worried about that, and that's part of why we also obtained the EEG kind of directly following the visit, because it had seemed like times in which he would have breakthrough seizures, he would have a lot of behaviors in the days or even morning leading up to that. And so even though it was being managed by clonidine with his psychiatrist, our concern was also that this was almost an aura at times.
Right. So this is being managed by a psychiatrist, which is interesting because, as many of you know, pediatric neurology are all a lot of pediatric neurologists managing both behavior and seizures, right? So I think that's interesting to itself. That's not typical, right? That's the issue of transitioning, getting in trouble transitioning to find a separate physician, right? Care provider.
Mm-hmm. Definitely.
Do you guys see behavior challenges with Epidiolex, like a side effect of Epidiolex?
I've treated quite a few people with Epidiolex so far, off-label, with and without Dravet. I've seen, there's reports that that it can be in my small, and there's reports that it can increase sort of irritability and agitation. The hope is that it's anxiolytic, but I've found it to be pretty behaviorally neutral. I also am like curious about this weight gain issue. I don't know if maybe like the difficulty with, I've seen it cause weight loss, but I've never seen it, nor have I heard of it causing weight gain. I wonder if the same difficulty the young man is having, is having managing, impulsive behavior and like regulating himself in terms of habit and medication administration. Maybe similarly he has a difficult time regulating food intake. I don't know if gorging is an issue, but certainly overeating is kind of ubiquitous in this population, and maybe those things are true and unrelated. And I'm not sure that that may have been something to explore further. Are you really sure? Maybe we're just under treating, and the weight is a separate issue. Also, I'm sorry. Now that I'm talking, I'm just going to keep talking if that's okay. I'm sorry. Just wonder, in the same choice, you'd asked about the question of injury from missed medications of breakthrough seizures, but then also the choice of clonidine. We see it so frequently in child neurology, but if compliance is an issue and he's on both clonidine patch and the oral regimen, that's two things to keep track of. And either way, you could see, spikes in in blood pressure just from managing it, regardless of, behavioral dysregulation. I don't know if maybe, and then there's the issue of suicidal ideation. I wouldn't necessarily expect interictally, certainly like, interictal agitation and like ramped up self-injurious behaviors, but I don't know about like longer term alterations in mood. So I would really question if that's the case. You don't want to have him regulate his own medications if he's thinking of killing himself all the time. He has difficulty with impulsivity, and he's got all of his pill bottles right there. That's something else to think about just in terms of risk of suicide. Thanks. Sorry, didn't mean to talk for so long.
It's a really great point. I think a lot of questions about the behavior challenges and regulating his behavior and mood disorders that he might have coming into these teenage and adolescent years before deciding on medication autonomy. So I would like to pose a question to the group. Let's say we cure his whatever is underlying depression, irritability, mood dysregulation, behavior, irritability. Let's say that's all cured with like magic extended release clonidine or something that it's every day. Then what? He still has it seems like there is potentially either intellectual disability, there's autism, there's other challenges with his decision making. How do we then think about introducing autonomy over his medication administration?
Well, I'd be curious to know what's been going on. Like, how has the family, because obviously the family still has an important part to play in terms of what they've been able to do, cutting the umbilical cord or control. So what has been the sense so far in the family's level of ease towards allowing some level of independence for their child, their son or daughter?
Yeah, that's a great question to bring up. Definitely some reticence and difficulty in allowing that. And I
Right.
think some of that has been made more difficult by the fact that, he's had such good seizure uh, resolution that almost at times his clinic visits were very far between. So these conversations weren't as frequent. But even more recently, they definitely have a higher role in his healthcare kind of decision making and kind of his dependence.
Because often you're counseling the family. I mean, they could be part of the problem. They could be what's more difficult for this individual to become more independent and self-thinking when the family members of some are like an umbrella parent, as many of you can appreciate what that means, about letting go and trusting the individual who, I guess, because they have a lifelong developmental disability, that they're very worried and concerned.
Yeah. I would love to hear, based both on this and on what you were discussing earlier about some of the long-term plans for living, what are some ways in which you bring those up with parents? Because I often find it difficult to kind of use wording as well that they don't find, either judgmental or they become defensive of. So if you, Dr. Keller, or anyone else wants to give examples of like how you bring this up too, I think that would be
Well,
really.
I don't want to suck the oxygen out of the room, but I'm actually going to answer a question with a question. How many times do you think neurologists even delve into that issue at all? And I'm serious. I think it's a matter of, do they feel, at least on the adult side, I think this might be a difference between a pediatric neurologist and an adult neurologist, where they feel that they're even privy towards even talking about that is even relevant to a conversation that they are having about that. They might purely, I'm just using this as a general sense of how adult neurologists may feel. They might feel their role is purely a medical role and not a psychological, social role about that. And I'm being rhetorical, believe me, I am in this comment, but I really think and that's why I'm posing it this way, Maya, because they may not even ask or feel that it's up to them to say anything or their business.
Yeah.
I don't know how other feels about that, but I think that might be different between a general neurologist and a pediatric neurologist. They say, "Oh, this is not me. Go speak to your PCP or family and all that." But I do feel, for me as an adult neurologist, it's something that I've enriched that interesting conversation personally. I find it very interesting to get into the issues of the parent and the individual and really what's going on, and you do have to play like armchair psychologist or social worker a little bit if you're so inclined. And I feel that's a wonderful conversation. I personally like doing that.
I
Yeah,
also think as this kid's a little older, but I think at a little younger age during the period of transition, I might have brought it up. And if they had an interest in being independent and needed support, you could also pose it as a potential IEP goal and get the school involved to help them and help the family have, that kind of mindset and approach as they get older, that they understand their condition, that they can go to the doctor by themselves, that, either you work towards it or it's a failure and you realize you need the support. But I think starting the conversation much earlier and taking advantage of the school district is beneficial sometimes.
Thank you.
Sometimes. I mean, I'll add also, hi Maya. But I would add that I've struggled before to have the schools take transition very seriously if the transition is not academically oriented. And so I think in some ways it does really fall to medical providers to lead that conversation and to make sure that that's going in a productive way. But Cheryl, I think you're absolutely right. The school can be a great resource sometimes if they're sort of enabled to be.
mean, yeah, you're right. I mean, either way, but it's just the idea that you bring that conversation up like earlier, like, 12, 13 years old, you start to talk to them, you start to make sure that they're doing it at the school, and you start to ask them what they think about their condition and if they feel that this is something they can manage or not.
Yeah, Booma, thanks.
First of all, thank you, Maya, for just a really compelling presentation, and it's a really great way to start out the series. I want to kind of echo and emphasize some things I'm hearing, and really target questions to people that are either interested in going into adult neurology. I know Diana's on this call and is going to be starting, or longstanding adult neurology practitioners like Seth. I do think that caring for people with childhood onset IDDs or childhood onset neurodevelopmental disabilities, it really is and to echo what Cheryl said, on the pediatric neurologist to have the long game in mind, what I call the long game in mind from the outset. I think a lot of our families, I'm a CP specialist, and when I talk to our families about the importance of hip surveillance to prevent future arthritis, arthritis for when our kids are, late adolescence, early adulthood. It's an interesting discussion because a lot of families there's so much going on in the present. It's hard to think about the long game, lifelong care. And we really do try at a very early age when kids are, when I first meet them, I tell people at age 2, age 3, I say, I'm in it to talk about interventions that will have an effect on this person when they're going on their first date, when they're thinking about job placements. Like I'm in it for their lifetime, because things we do now have an effect across the lifespan. And I do think that's, maybe we focus a lot on transition, but I think thinking about setting that mindset very early on is important, particularly in DEEs like Lenox-Gastaut, where families are, I was told my kid wouldn't survive through past age 5. I think making sure families understand that it's good to think about adulthood is important. And then with that in mind, I don't know that a lot of families have had that perspective from pediatric care going into adult care. So I am curious, from people that are planning on having these discussions fresh, like what are some of the strategies that are used, mainly including medication autonomy? So how do people approach that conversation for someone who has not had that autonomy, even though they've reached adulthood and could have that autonomy? How do you approach that, or how would you approach that in this scenario? I'm hoping for some specifics from somebody.
So I know that Alicia just posted in the chat something that I was thinking about. Just in my experience so far, I've seen non-IDD, NDD adults that just may have very low health literacy or other sort of cognitive impairment, sort of being referred to either these apps or services that provide ready packages of daily medications. I'm sure there's different degrees of that, but your comment made me think that would be sort of one tool. And thank you, Maya, for sharing this case. It really made me think about like validating these tools, and both the ones you mentioned are not validated for IDD and NDD, and I can imagine that is the challenge of all challenges, and we're sort of validating different techniques with each individual, just because there's such different components to that autonomy. There, you can imagine understanding how much, when, and then the sort of routine of it in and of itself. So just wanted to throw that in there.
I think the one thing that's going to be so interesting is that the issue of transitioning will basically never stop. So as an adult neurologist, I see the issue of transitioning going on throughout their lifespan, even beyond a 19-year-old, as you can appreciate. The living at home, the parent gets older, the so-called child is now in their 30s and 40s and 50s. Now the adult is now in their 60s, 70s, and 80s. And I often, in my practice, I see a lot of people that are trying to transitioning of someone that's already an older person, and that has its own issues into itself in terms of caregiving needs for the older parent, and how to get them into another mode of living situation, whether that's supportive or a group home care. So definitely, I just bring it up only to talk about transitioning isn't a lifelong issue that might happen. And then even if they transition into in a supportive situation, is that a static situation? Is that something that for the individual is going to be good for the rest of their life? I think all of us, have you lived in one place your whole life? Is it always the same place? So I think all of us can appreciate that transitioning in and out of life situations and challenges that happen all the way is a very fruitful thing that has its ups and downs and things like that. So it's always a lifelong dialogue that we all have to look at all the time.
Yeah, Seth, I really like that perspective. Transition is not like a train that leaves the station as soon as a person turns 18. And if you haven't transitioned successfully by that point, then, you know,
yeah, you're
too bad.
done. Then you're
Right.
done, right?
Right. It's, you know, I think that's a great perspective. It's a moving target, and the targets specifically, I think, are like the particular and specific skills that the person first and foremost values, and the people around them sort of value for that person's own sustainability. So things like taking medications, or even more specifically than that, swallowing pills, accessing the medication, putting the medication in the sort of daily, you know, dispenser things. You know, there are lots of sort of bits and pieces where that process can fall apart for somebody. And so being sort of like very specific with the things that are working or not working, and targeting those therapeutically, I think can be a really helpful approach sometimes, but hard.
Yeah, and you got to ask a lot of questions. I think that's really so vital. You have to like peel the onion, you know, to the layers of what's going on, of really understand what's going on. I mean, I appreciate the conversation you mentioned, Maya, about the Epidiolect, and it's not all empty like that. Because many people say you're not getting response to the treatment, and say, well, but maybe are they really taking it? Are they really taking the whole amount? I mean, that might seem simple, but that's really not always that simple for people to ask that and know.
I think in terms of something concrete in this age group, what I often do, because it's really hard to put it all on the parent or family or supporter, and all on the individual, or to be the doctor and be the one splitting it up. I bring in ABA, applied behavior analysis, which and I explain this looks a lot different in a 2-year-old than it does in a 22-year-old. And the goals in a 22-year-old are to meet your goals. So what are your goals for independent living? And then the behavior analysts and therapists can work with the individual and their life situation and their housing situation and all of their goals, and work on medication plans and help get to know them. And I say, like, listen, here, I can think of these ideas, like the pill dispenser and these things, but I'm seeing you for 20 minutes once every couple of months. A behavior therapist could see you a couple times a week or weekly or whatever, and really work with your goals, learn how to figure out what makes your loved one tick and motivate them and all of that. So that's where I recommend behavior therapy in adults. And it is possible.
How does the issue of just say this individual continues that breakthrough seizure, they were seizure free for all these years, you have a certain kind of life thinking you're going to be fine without seizures. Now that they're going to be, say, breakthrough seizures, and whether or not any further manipulation on medication, Epidiolect high dose, or switching or adding over, what would that mean, you know, if the seizure still happened for this person? What would it matter? Would it change anything? Would it change the way the person's living or not? And would it affect the way they think of themselves? So Maya, I'm not sure if you've had that any level, that psychological, philosophical conversation, but you know, right now it's, you know, the person's still having occasional seizures, and maybe they can't be cured, and maybe there are a lot of people, as we know with IDD, that the level of treatment is really more of a quote unquote control issue. It's controlling their seizures, because over aggressive therapy might be counterproductive. It might cause side effects and other things, and you may not be getting more control. So it's going to be an issue over time, aside from managing of the medication, about the reality of what does this mean for the individual who may eventually not have perfection in terms of their seizure control. I mean, I'm not saying that's true, but that might be the case.
Definitely. And I think I have seen cases on both ends. Like oftentimes, in this case, I brought up that, fake Kevin, had not remembered any of his seizures. And so to him, it was almost a surprise, even though dad had been telling him you had a seizure, it was almost a surprise that he had 5. So to the extent of that, it wasn't affecting his self-confidence. It wasn't affecting, as I see with some patients who have focal seizures and are very kind of traumatized by it, it wasn't traumatizing him. It wasn't affecting his kind of view of himself, but it definitely was getting in the way of his ability to do certain things. Parents had now installed a baby monitor in his room because he had gone 9 years without seizures, and now they were worried he'd be throwing up when he's having a seizure and they're not viewing. They had, they had taken back, some of the autonomy that they had started to try to give to him. And so a little bit of, both of those things were affecting the way that he was living. But I've seen other cases in which we've had this discussion with parents who are very reticent to start new medications, and we see their child either having an effect on their self-confidence or being traumatized by, the over evaluation as well of seizures. So I think I've definitely kind of seen it play out in both scenarios, and it's difficult to parse out what's best for the patient. In his case, I'm hopeful that we'll be able to get it under control without, too much adverse effects from the medications, but it's possible, sometimes I've seen pickup in, his case doesn't have a focal cortical dysplasia, but we haven't had an MRI in several years. Sometimes I've seen a focal cortical dysplasia pick up after years of not having anything and then be very difficult.
But the EEG was focal. Did it show, like, was it right temporal? I'm trying to remember where it located. Was there like a right temporal focus a little bit?
It had bilateral temporal foci.
Right. So which is the most symptomatic side? What's more symptomatic? I don't know. Maybe maybe a resection down the road might be relevant or not. But I do think it's very interesting to see the parents' reaction. They got the baby monitor, they're cutting back. So playing psychologist here, what do those reactions do to Kevin? And how has Kevin reacted to his parents? Are he now can't go out, and now he can't be a friend, and now he can't do this activity? I mean, so the reaction could be an overreaction that could also have implications upon how he's perceiving everything, right?
Yes.
Yeah, that's why I think putting the supports in place and being open with him and his supporters, whether it's his parents, his vocational program, that we all need different supports at different time in our lives. So figuring out what supports he needs now for medicine, and then different supports for his job, and sort of framing it and helping him realize he needs help in different places, different ways.
So, Mai, what is your plan? I mean, in terms of where you're going next step with Kevin, what I mean, I have some general sense what you're doing. So what are you going to do or thought you're going to do to help him out?
Yeah. So at this point, because he was also at a lower than normal maintenance dose of Epidiolex, and because he was not having a lot of medication side effects, we were initially up titrating the Epidiolex in part to give him a little bit of buffer room as well. And then trying to recruit him, even though it's not validated for the EpiTrack, we do have this group now that's trying to kind of evaluate understanding and then try to help set goals between clinical visits. So we felt like that was a better support, which can provide a little bit more time and a little more understanding for both Kevin and his parents about his epilepsy medications. And so that was our kind of short-term goals, but long-term goals would definitely involve, further discussions around, what both him and his parents' thoughts of living situation and medications would be. Because right now it definitely seems like, as you're saying, any kind of new setback in the plan really led to a lot of reaction.
I would imagine. Now, I think the issue, I mean, it was mentioned that doing another genetic analysis, that makes sense.
Mhm.
MRI the brain, you mentioned that makes sense. Now, do you also do any seizure calendar usage? I'm curious on how you or other people in the call use seizure data collection.
We have often, especially for, I think there are pros and cons, especially in this case, for a father and parents who are so kind of um, have such a close eye on their child. Obviously, we don't want to create more reason for them to be, videotaping him at all times. But at the
Right.
same time, seizure calendars are very helpful for kind of connecting that time point of like when he missed medications to when he had the breakthrough seizure, and similarly when he was playing video games to when he had breakthrough seizures. But I'd love to hear other people's input on that too.
Yeah, I wonder if that could sort of serve as a way to teach him or to show him that he is indeed having seizures and these are the triggers. And I mean, it could be used as sort of an educational or motivational technique for him. Although the risk is that the parents are going to continue to, it'll sort of like feed into their anxieties and concerns. So I think that does have to be balanced.
Yeah, but I like that idea, Benjamin, also, especially since he's so story motivated. Like he likes video games, he likes looking at stories. Maybe putting that side by side could help him with the teaching.
Yeah, I mean, if he's going to be mature enough to really manage his own self, then he's got to be mature enough to appreciate the oversight over his own situation. So he, and not that you need to test his maturity, but in what you do, I mean, what's his level? I mean, would he ever able to manage his own seizures and insight? And God willing, I mean, hopefully he'd be able to do that. I use seizuretracker.com. That's kind of mandatory in my practice. I don't know if you guys know or use seizuretracker.com. I think it's a really great tool and that's the name of the website, called seizuretracker.com. It was created, if you guys are not aware of it, it was created by a guy named Rob Moss. And that's it. Thank you, Ben. And Rob Moss' son his son has tuberous sclerosis complex. And he basically is a programmer. God bless Rob Moss. He lives in Alexandria, Virginia. And he got tired, I guess, going to his doctor's offices in the East Coast about bringing in data, paperwork. And it was a voluminous kind of thing. So he created seizuretracker.com. And seizuretracker.com, as you look at it, has longitudinal analysis. It really does track objective information, and you put in what you put in terms of getting out of it. It's not just isolation information on the number of seizures. It qualifies the type of seizures, the triggers, or you put in your medication changes, and it tracks over time. It's HIPAA compliant, it's secure. And seizuretracker.com, not to really sell it, is now used around the United States, around the world, for data collection and research studies. It's really validated to be a really good tool. So I really like it.
Thank you for sharing that. It's in the chat now from Benjamin for anyone.
Great. Do you have other good medication, Maya? If the Epidiolex doesn't work, do you have like plan B after titration? Would there be something you in the back of your mind eventually you might go back to?
Yeah, our, plan B was most likely one of the newer medications. So Xcopri had not been tried. Cenobamate had not been tried on this patient because he had
Right.
been seizure-free for so long. So that was one of the possibilities. But he's gone through, quite a few classes of meds already.
Yeah. Yeah. I like that idea of what the next approach could be, and those drugs in particular. Yeah, I do use a lot of Xcopri. I do use a lot of Fycompa. And I guess with the drugs, you'd also be looking at about any challenges that would affect his behavior, because that's the other comorbidity. Would any change in any medication, increase, decrease, change, have any downward impact upon the behavior that is, you don't want to make worse. You have to always be careful, of course. And Fycompa into itself, for those, and I use a lot of Fycompa at higher doses, over 6 to 8 to 12 milligrams, absolutely could be problematic for behavior. Lower doses, 2 milligram, 4 milligram, even up to 6 milligram once a day. It's a nighttime drug. It's long acting forever, is often good. And it's a good medication, not to really sell it. It's actually good because it's a global treatment. It can be used for partial and for a generalized.
I also appreciate now that you're bringing that up, the comorbidities as well. You know what Benjamin Margulis was bringing up earlier too, of how it's so important in cases like this to not take some of the comorbidities at face value. Like partially the behavioral outbursts, like we were saying, could be the aura, but I really enjoyed the point that you brought up before, Benjamin, about like the overeating potentially being related to some of his impulsivity and some of the other things.
And GI difficulties is a big problem with Epidiolex, gas, bloating. I mean, Epidiolex, it's a liquid. I don't know if anyone tried Epidiolex. If anyone drank it. I'm being facetious. I can't say I've drank Epidiolex, but I know that it's the taste of it or smell of it, and definitely the liquid of it is a little tricky.
Well, thank you so much, Maya, and for everyone for the conversation about transition and decision making. I wish we could come to easy answers and leave this with a here's what you do, but I think we often leave with more questions. But it's so helpful to have this group to bounce those questions off of, so we know we're not alone in how we ask them and how we think about these cases. So thank you.
Thank you so much.